For pregnancy and lactation professionals and parents-to-be, the First Exposure podcast offers safety information and clinical guidance about medications, drugs, and environmental exposures. Join us at firstexposure.ca.
So welcome to the First Exposure podcast. I'm Tali Bogler. I'm a family physician and chair of family medicine obstetrics at St. Michael's Hospital and medical advisor for First Exposure. I'm also a mom of 3 kids. Today we're going to be talking about cannabis use during pregnancy and lactation. Cannabis use during pregnancy and lactation is a very hot topic right now, and so this will actually be a 2-part episode. In the first episode, we'll be discussing some of the motivations behind cannabis use, challenges of disclosure in healthcare settings, and the latest evidence on the effects of cannabis on fetal and neonatal development. With me today, we have 2 experts in cannabis use in pregnancy and lactation. We have Dr. Oyedeji Ayonrinde and Dr. Suzanne Turner. So I'm going to ask both of them to introduce themselves. Deji, why don't you introduce yourself first?
Well, thank you so much, Tali. It's a pleasure to join my colleague Suzanne on this podcast. So my name is Oyedeji Ayonrinde. I'm professor psychiatry at Queen's University, Kingston, Ontario, and the division chair for community mental health. And I run a cannabis consults clinic as well, providing advice on safe and preventable cannabis use through the lifespan.
Great. Thank you. Thank you so much for being here. And Suzanne, why don't you introduce yourself as well? Thanks again.
Yeah, I'm Suzanne Turner. I'm a family doctor in the community. I'm an associate clinical professor of family medicine at McMaster University and family practice obstetrics, head of service at St. Joseph's Healthcare Hamilton, as well as head of service for the substance use inpatient consult service. And I run a community program called Prosper, which is Program for Substance Use in Pregnancy, where I provide care to women with substance use disorders in pregnancy.
Great. Thank you to both of you for being here. This is a really important topic. And if it's okay with you, let's jump right in. So my first question are on the various components of cannabis. There are so many different forms out there, various strains. What would be important for listeners to know in terms of the difference between, let's say CBD and THC and the various components and products that are there? And Suzanne, do you mind if you start us off with this one?
Yeah, happy to. So I sort of think of the 2 components separately. So the first one we need to talk about is THC. This is sort of the classic component of cannabis that we all think about. From my perspective as an addiction medicine physician, this is the one that I think about the most, mainly because it is the addictive component in cannabis. So it releases dopamine, which is part of the reward pathway. And as the potency of the THC increases, you can think of it as increasing the addictive potential, but also things like psychosis, paranoia, anxiety. And it's also what's associated with the withdrawal syndrome associated with it. The concern in pregnancy is that we know that THC crosses the placenta, and THC receptors are present in the fetal developing brain and throughout the body, actually. But the brain is the part that we're most concerned about from very early in the pregnancy. So we know that the is exposed to this. The second component, CBD, is less studied in pregnancy. It's thought to be an anti-inflammatory component. You'll see papers and physicians talking about the properties in terms of chronic pain. And we know that as the THC content goes up, then the CBD content typically goes down. The issue is that we don't really have any safety data in pregnancy, and we know that CBD receptors are present in the fetus starting around 14 weeks gestation. So again, very early in the development of the fetus, we see these present.
Deji, I'm gonna turn the next question to you. So in your experience, what are some of the motivators that we see for people to use cannabis, specifically in the reproductive age?
Yes, whilst many people think cannabis used in the reproductive age is to get high and have sort of fun type experiences, a lot of people actually use cannabis to also modulate or to try and reduce symptoms they may be experiencing. Some of the common issues in the reproductive age are sleep disturbance, and some of the cannabis components can, for some individuals, give them experiences of enhanced sleep. Common in the reproductive age are anxiety symptoms, and a lot of people then may use cannabis to try and modulate their anxiety, use cannabis also for depressed mood or trauma experiences. ultimately to alter the experiences they're going through that they find negative. Now, one of the critical risks with that is there's no single cannabis. And we heard Suzanne mention about THC and CBD. And the combination of the THC and CBD have different characteristics. So whilst one person may benefit from sleeping better from using a particular cannabis product, another person could use something similar or another product ratio and feel paranoid, which is not the way one would want to go through pregnancy, paranoid, suspicious, with the impact it may have on relationships and mental health. On the whole, many people actually do use cannabis for medical purposes or with a view to alleviating distress. And that makes sense, even though we don't encourage it, because if you can't get to see a family physician, or if you've got symptoms that are causing you distress and you don't want to go to the emergency room, or you're having an experience and a friend of a friend of a friend says, try this, it worked for me, that may be an alternative pathway to care. And we really need to know a lot more about this and understand people's reasons for using it in the reproductive years.
Thank you for that. And just to a follow-up question to that, in terms of anxiety, and either of you can answer this, is THC effective for anxiety in general? Do we have good studies to even show that? Even if somebody says it's effective for me, do we have good studies that it actually works for anxiety? Suzanne, I see you smiling, so I'm wondering what your answer to that would be.
So generally speaking, some people can have a reduction of anxiety initially. From my perspective as an addiction medicine physician, there's a couple of things. One is that some of the older studies that we have use significantly lower THC containing products than we have available in Canada now. So whether that's through a licensed producer like we have in Ontario, you're going to sort of the Ontario cannabis store, it's very difficult to get low dose THC containing products, so less than about 10%, which is really what has been studied. But the other component to realize is that if you're not buying through a licensed producer, you're buying through another pathway. So these would be like the non-prescribed pathways or the non-legally sanctioned pathways. The THC component in these products is very high, so upwards of 20%, sometimes even 35%. We know that the risk of withdrawal in particular is very high as the THC content goes up. And withdrawal is associated with a huge increase in anxiety. So often what I see is that patients who particularly are using cannabis daily or near daily will have a significant withdrawal syndrome, which actually worsens their anxiety. So they actually need to use more and more and more cannabis, particularly the THC component, to get mitigation of that withdrawal. And over time, that withdrawal leads to more and more anxiety until at some point they're not actually able to mitigate it anymore from using their THC products.
Okay, thank you for that.
Yeah.
That's really helpful. Deji, you wanted to add to that?
Yeah, just adding to what Suzanne said, and in some people at very low doses, as Suzanne stressed, of THC or potencies, there might be reduced anxiety. But as the potency goes up, so does anxiety. So you think of it as reducing anxiety in very minuscule doses, then gradually increasing anxiety, then the onset of paranoia, which also increases anxiety. It's no fun being paranoid, and the emergence of psychosis, which also can complicate anxiety. So they're complex mechanisms, predominantly THC related. Some people do suggest that CBD reduces anxiety in specific situations. The evidence isn't sufficiently robust for us to recommend this.
Okay. Thank you. So turning our attention to pregnancy, because this is, why a lot of followers are listening. What are some of the motivators that people are using potentially in pregnancy? Now, of course, we could have some people that were using previously and want to continue using, but I've also heard, even in my practice, there's some notion around using cannabis to help with nausea in first trimester or vomiting in first trimester. What are some of the motivators both of you are seeing in terms of use in pregnancy? Thoughts on that. Suzanne, do you want to start, please?
Yeah, no problem.
Yeah.
So I would agree, Tali. I mean, in my practice as a family physician, I see a lot of patients who are interested in using something that's natural when they are pregnant. Patients are obviously very concerned about the health of their pregnancy. There's a lot of differing opinions and a lot of noise to move through when you're pregnant about what's safe and what's not safe. And these things can be changing very quickly. So I would say that a lot of people who use cannabis for nausea and vomiting in pregnancy are really kind of moving towards that because there aren't a lot of other natural products that they feel are available to address that. And as we know as clinicians, and as someone who's been pregnant, I can say that nausea and vomiting in pregnancy can be absolutely debilitating. There is no question that this is, something that is causing a lot of distress in the patient population. And, being able to sort of use something that's natural is a motivator for a lot of people. It kind of comes back to what we were talking about before, that essentially the cannabis has not gone through kind of the same process that we have as other medications that are used for nausea and vomiting in pregnancy, and many of which have been around for, more than 30 to 40 years. So we have very good safety data to say that they're both safe for the pregnant person, but also for the fetus/neonate. And so when I'm discussing it with patients, I really try to say my job is to do no harm. I know that THC exposure, particularly in all trimesters, has consequences to the fetal development, and that we have very good medications available that can be used to mitigate nausea and vomiting in pregnancy. The other thing we need to think about when we're using THC for cannabis for nausea and vomiting in pregnancy is there's actually something called cannabis hyperemesis syndrome, where with chronic cannabis exposure, you can actually have the opposite happen. So essentially, THC exposure resets your nausea and vomiting center in the brain, and you actually vomit more associated with your cannabis use. And that can be very difficult to treat. We don't have good pharmacological agents to help with that pathway. And so you can actually have the opposite effect of what we're going for. And again, we have really good, safe medications that we can kind of either use alone or layer in using multiple medications together that we have good safety profiles for.
Yeah, thank you for that. I just want to add to that, obviously when it's debilitating nausea and vomiting, we need medications. But before that, there are some sort of natural, quote unquote, remedies that I often recommend to my patients. So for example, ginger, ginger ale, ginger tablets, ginger candies. Vitamin B6 is really helpful. So there are, and other little tricks that people can use, having little small meals, having something to eat or a cracker before brushing your teeth. So there are actual strategies that I think we need to make people more aware of. And yes, people often think of, cannabis as a natural product, but not everything that's quote unquote natural is safe, right?
Yeah.
So Deji, go ahead.
Yes, I'm just going to add, and thanks, I agree. The one thing that stands out for me certainly is I've never been pregnant, so I don't have the privilege both of you do have. However, we do know that even just the misreading of evidence or partial understanding or misinterpretation of evidence. So yes, there are some cannabis products licensed for nausea and vomiting. However, it's in the context of chemotherapy treatment in cancer care. And sometimes the references made are then made to nausea and vomiting and leaving out the cancer care. So for some of the people listening as well, the lingo you may hear either directly or share will be things like greening out. And so cannabis makes people green out. And the mystery of the green is probably if you vomit and vomit and vomit, you'll get to the bile of the colors. Sorry if this putting people off the podcast, I'm sorry. We keep it very real. So it's something real. Cannabis can cause the vomiting itself in cannabis hyperemesis syndrome, misreading or misattribution of evidence from oncology being then brought into pregnancy, and that's a misattribution.
And to build on that, actually, Deji, as someone who cares for pregnant people regularly, similar probably to Tali and maybe you yourself, our first goal is to do no harm. And certainly we know that the neurotoxicity associated with THC would make it very difficult to prescribe the same medications that are used for nausea and vomiting and chemotherapy in pregnancy because of the very significant harms associated with it. So I think that's a really good point, that while we have products that are shown to be efficacious in chemotherapeutic nausea and vomiting, that in pregnancy, we'd be very concerned about the impact on the developing fetus and then the neonatal developing brain.
Can we touch on that a little bit more? So let's talk about what we know about THC specifically for the pregnancy itself, or maybe for the pregnant individual. So thinking about pregnancy outcomes, any adverse pregnancy outcomes, and then we'll split. The second piece to that is, what is the effect on the developing fetus, both short-term or long-term? So there's lots to cover. I'm happy let's just break it up. So let's start with the pregnancy itself. Are there any impacts of using THC? And obviously, are we talking about once a week? Are we talking about on a daily basis? I know that can be a little bit confusing as well, as in terms of how you counsel risk. But what do we know about its use and associations with the pregnancy itself and pregnancy outcomes? Suzanne, I'm going to turn to you for this.
Sure. So in pregnancy, we essentially, we're really looking at probably the most well-studied outcome is related to fetal growth effects. So while we're talking about kind of the size of the baby, this is actually also considered like a pregnancy complication, because you can imagine the anxiety and distress this causes if you're the pregnant person and you hear that your baby is smaller than expected for age. So we have sort of three what's called longitudinal studies, where they followed pregnant people who were using cannabis near daily. So in the addiction medicine world, that's sort of considered more than 2 to 3 times a week. And they followed them in pregnancy, during lactation, and then followed the offspring, so the children, for a long period of time, like decades afterwards. And these studies really inform what we know about pregnancy and the postpartum and the neonatal development. But 2 of those longitudinal studies and another study that's come out more recently basically show that there's very good evidence that THC is associated with lower birth weight and what we call growth restriction. So that's sort of a smaller than expected baby. And they were able to control for a variety of other reasons that can cause growth restriction. So things like tobacco use, for instance, is also associated with an effective growth restriction, but they were able to sort of tease out the THC related exposure and the association. Again, it's very hard to say, with confidence, but we can say that these studies kind of reproduce this. So lower birth weight is certainly a component. In one of the longitudinal studies, they also showed that length was impacted. So the overall size of the baby was smaller than expected. So that's one thing that's been kind of consistently shown on the pregnancy side. And the other thing to know is that it's really dose dependent. So the earlier people were able to cut down on their exposure, as well as those who were able to go, let's say, from daily to near daily, were able to show a difference in that. So those who really kind of reduced, it's not an all or nothing thing, which I think is also helpful for people to hear. Obviously in my world, I'm usually focused on trying to eliminate cannabis, but certainly we know that the higher the dose of THC and the more exposure to that THC we see, the more effects on growth we're going to see in the fetus and therefore the neonate. So that's the main component of pregnancy related data that we have right now.
Thank you for that. Deji, anything you want to add to that?
Yes, I fully agree with the point Suzanne has made. And another consideration would be the growth of the organs that we don't even see. So, you've got from the top of the head to the toes, as in length, and then the weight and size. But we've also got things like the brain. And whilst we talk so often about the harmful effects of cannabis, particularly THC, on the developing brain, on the ultra rapid critical developmental stages, when the baby is in the womb, and the developing brain at that stage critically is sensitive as well. Now, there's some suggestion about the link to specific disorders. So there are some suggestions about neurodevelopmental effects on the brain. There are some studies looking into potential effects on IQ and so on. So there's signals suggesting those harms, but that's an example of the less visible organs that may have enduring effects on the unborn child.
Deji, I think that's a really good point if I can build on it. So, I do work in a variety of substances, as we all do, but I think one of the things that's really compelling to me are these three large studies that I mentioned that were longitudinal. So they looked at a variety of different populations. Both there was an Ottawa-based study that followed people for decades, sort of the offspring for decades afterwards. There was a study from North US states where they looked at the same, and then one from, I believe, the Netherlands. These are very important studies for substance exposure because if we think about it, about something else, another exposure agent, where we had these three very large studies showing that we were concerned about the neonatal neurodevelopment, I would think that we might have a different take on it. As a researcher in substance use disorder, I actually think the data is very compelling about the association. Things like attention deficit issues, impulsivity, depressive symptoms, hyperactivity, even though these three studies used different outcomes and different metrics to look at that, the fact that they saw these similar associations and also saw worsening neurodevelopmental outcomes for the children that were associated with an increased concentration of THC has me greatly worried. And I think it's a really important thing to get that information out. Obviously, our patients can make their own decisions about what they think about that data, but I think it's just not as publicly discussed as others. The other issue is because it's sort of hidden, as you sort of mentioned, Deji, we're not looking inside the brain, and that the developmental differences aren't seen until about school age. It's very difficult to make those correlations, which is why these prospective longitudinal studies are really important. They're very expensive to produce. And the fact that we have three that all show very similar data where they followed children for long periods of time afterwards really is compelling to me as a provider. I think it's very important to get that information out, because if I think of some of my patients who are hesitant to take things like gravel in pregnancy that has, 30 plus years of safety data. And then, we have these longitudinal studies that are showing that THC is potentially very neurotoxic to the developing fetus. It's hard to make that corollary as a clinician. So I think it's very important for the public to get that information moving forward.
Thank you, Suzanne. Both of you touched on more of the long-term effects that we see in children. What about some of the short term? So let's say someone's been using cannabis throughout pregnancy up until the end. Do we see any short term? So we spoke about the growth. Anything else in the short term period in the babies that we see?
Yeah, so there can be kind of a discontinuation syndrome associated with THC in the neonate. So it's usually very short-lived, sort of 24 to 48 hours. What that can look like, just like in adults, there can be a withdrawal syndrome associated with THC withdrawal. We talk about jitteriness maybe increasing, so that's more kind of limb movements than would be considered quote unquote normal in the neonate. We can see feeding difficulties. So babies can have kind of a nausea associated with the discontinuation, and we might see feeding difficulties in those babies. And then some difficulty consoling as well. That's not as well defined in terms of discontinuation syndrome as we might see with opiates, for instance. We have a very good kind of understanding of what that will look like. The good thing is that the treatment for that kind of discontinuation, if the neonate has it, is really what we call kangaroo care. So that's snuggling your baby, doing skin to skin with your baby, a low kind of noise environment, very dark, kind of soothing environment for the baby. So there typically doesn't need to be any medications that we administer. Essentially, I prescribe cuddles to the babies under my care, and parents really like to provide that. So, but certainly there can be some association with, a baby that may be a little bit more difficult to console.
Okay. Thank you for that. That's really helpful. So in terms of we talked about the long-term outcomes that we can see in children and just sort of the cultural sort of acceptance or perception around cannabis. How do you think about that in terms of the difference with alcohol? I mean, do you think there's, people see it as bad as alcohol, or because it's seen more natural, that maybe it is safe? I mean, how would you make the comparison? I know you both deal with various drugs and not just in pregnancy. What is your experience with cannabis specifically in comparison to some of the other drugs that you have experience with?
Yeah, well, cannabis is now increasingly socially acceptable. And if you look at the Canadian Cannabis Survey and many other surveys, perception of risk of harms and the social acceptability, cannabis continues to be more and more acceptable. So alcohol's up there. Tobacco is declining and cannabis is on the way up. And that's really striking because a person could light a cigarette and say, oh my God, you still smoke? And another person lights a joint and someone asks, oh, is that good weed? So the attitudes are changing. We're also in this very unique position where there are some cannabis products approved by health professionals for health conditions. So we have recreational cannabis use. We also have cannabis used in the sort of health sphere. And that can be a very confusing message for many people because, hold on, that doesn't happen with alcohol. I mean, not in contemporary care. So it's more socially acceptable. We remind ourselves that cannabis isn't only smoked. There are edible products that come from gummy bears. They can be ingested through drinks and so on. And in other industry, illicits predominantly, there are cannabis products that can be used through the backside or as pastries as well. I do not encourage anyone to purchase products from illicit sources, but it'll be naive to think they don't exist. So with these different routes of products, there are powders that can be sprinkled into a drink. There are oils and tinctures as well. So there are so many. And when I teach and talk about this, you could have 10 people at a dinner party using cannabis products of different preparations, and others may not even be aware. So the sort of more familiar smoke, and the language around the terpenes and the smell of cannabis smoke. Cannabis is not only smoke. A quick add-on is reminding ourselves that when we say cannabis, it's just like saying dog. What breed? Is it a Chihuahua or a Great Dane or a Rottweiler? So we're using cannabis here, but it's critically important to know the numbers. What's in it? People are vaping cannabis products now with 80, 90% THC. There are products called shatter, and shatter by name, shatter by nature, that are extremely high potency products. And it's a race to the top. The potency is going up and up and up. And once again, the language about good weed isn't because it's not got herbicides or insecticides and so on in it, or pollutants. Now the contemporary language around good weed is potency. And by potency, THC.
But I hope people enjoyed listening about cannabis use in pregnancy and lactation. We covered a lot of ground and a lot of evidence, and thank you for opening up the discussion at the end about just the overall culture and how we can all do better, together, and open those lines of communication between us and patients and healthcare providers, and just so that we can talk about this and review the evidence so that people can make informed decisions that is best for their health and their baby. I want to say a huge thank you to Deji and Suzanne. Really, it has been so wonderful to have two experts in the field sharing their time and knowledge with me, with everyone who's listening, and just answering these really important and critical questions. For more resources on various topics, please visit firstexposure.ca. Thank you for listening and joining us today. If you found this conversation valuable, be sure to subscribe, share, and stay connected for future episodes. Thank you so much. That's all we have time for today. Thank you so much to Deji and Suzanne for sharing their expertise. We'll be back in part 2 to continue the conversation and dive deeper into the evidence around cannabis use during pregnancy and lactation. Don't forget to subscribe and join us for our next episode.
The First Exposure team acknowledges that our office is based on the traditional territories of the Anishinaabe, Wendat, Haudenosaunee, and the Mississaugas of the Credit, though the impact of our work can be felt across Turtle Island. First Exposure is committed to nourishing respectful relations with Indigenous communities whose knowledge of medicinal plants and environmental substances are a foundation of the pharmaceutical science on which First Exposure depends. This project has been made possible thanks to the vision and support of the Vora Miller Foundation and the participation of the Dalla Lana School of Public Health at the University of Toronto and Health Nexus.